I'm Dr. Nick Vogelzang from the Comprehensive Cancer Centers of Nevada in Las Vegas, Nevada. I also work for and with U.S. Oncology. I'm on the executive committee, research executive committee of U.S. Oncology. I'm a professor at the University of Nevada, and I'm also the ASCO spokesperson for the 2012 press meeting and briefing. The long-term outcome of men with metastatic, hormone-sensitive or castration-sensitive prostate cancer has improved dramatically by the use of these hormone maneuvers. However, once the castration is achieved, the men whose PSAs begin to rise or who develop new metastases have traditionally had a survival of about a year, perhaps 2 at most. Our early studies with mitoxantrone were a median survival of just over a year. Our median survivals of docetaxel were a median survival of about 16 to 17, maybe 18 months. However, now with the addition of Sipuleucel-T, abiraterone, enzalutamide, and radium-223, we are seeing median survivals that are pushing into the 4-year period. We don't have proof yet that these men are living 3 to 4 years, but to move from a 1-year survival to a 2-year and now closer to 3 or 4, I think is a pretty promising trend. Presentation by Dr. Ryan of the pre-docetaxel abiraterone study, we call that Cougar 302 or COU 302, was a randomization to either abiraterone and prednisone alone. So it's a somewhat difficult trial because this was a placebo, really controlled trial, and it was blinded to the PSA, and the endpoint was new bone pain, clinical deterioration, or new bone scan lesions. So there was a lot of radiographs, which we more commonly in practice substitute PSA for. So we were not able to look at PSA, and yet we were looking at all these fancy and expensive x-rays. And yet, at the end of the day, the PSA is as good a surrogate of all these things as is. Anyway, the survival is of marginally improved, but all the other endpoints, including progression-free survival, PSA control, radiographic response, time to deterioration of performance status, skeletal-related events, need for radiation, need for chemotherapy, all of these vital social and economic endpoints were vastly improved with the abiraterone. And the debate at the meeting was, is this survival trend going to lead to an overall survival? The Data Monitoring Safety Board stopped the trial a little early. We're not sure why, perhaps because there was crossover or other things like this. But the overall trial shows clinical benefit at many levels, and the survival difference was a trend. From my perspective, this drug should be used prior to docetaxel. It has a good safety profile. The safety was somewhat mentioned because there tends to be fluid retention, and about 19% of patients had some cardiac issue, maybe fluid overload related, and these are elderly men. But other than that issue, it was an amazing, clinically relevant drug. And therefore, in contrast to chemotherapy, this drug is far easier to give. So we recommend this drug now prior to chemotherapy. Now this will depend upon the third parties and the health authorities, et cetera, for approval, but nonetheless, I've already been able to give it to quite a number of patients in the United States because they are not candidates for chemotherapy. Well, the other major news, which was reported a bit earlier but now was updated to this meeting, was that enzalutamide, or MDV-3100, had a marvelous improvement in survival, almost a 5-month improvement in the overall survival of these patients after chemotherapy. In addition, the safety profile was examined very carefully, and there was less, apparently, cardiac problems with this drug than with abiraterone. The cardiac toxicity was 6% with MDV-3100 versus approximately 18% with abiraterone. Now, none of them were serious, and they were easily treated. On the other hand, the enzalutamide did have a seizure rate, and Dr. DeMono, who presented the data, was very well versed in each of the cases where a seizure occurred. And in fact, a number of them were in patients with frank metastasis to the central nervous system, or in one case, there was an inadvertent drug overdose of a known agent causing seizures. So it was, if you will, not really directly related to the enzalutamide. So that was helpful in putting that issue of enzalutamide at rest. But nonetheless, given the powerful effect of this agent in prolonging survival and all the other endpoints, PSA, pain, radiographic response, need for skeletal-related events, and decline in performance status, that drug is now an emerging, I would define it as virtually the standard of care. Well, it will certainly, if the health regulatory agencies approve the drug in both the United States and the UK, I would expect it to become the drug for patients who have previously had chemotherapy. Now, in that same space is abiraterone. In that same space is radium-223, which Chris Parker from the Royal Marsden reported just recently at ESMO as well. So we have now 3 agents, all of which shown a survival advantage, and in addition we have cabazitaxel, which shows a survival advantage in the post-docetaxel population. Therefore, we imagine, we don't prove yet, but that the post-docetaxel patient, if they could get all 4 agents, and each one of them showing about a 4 to 5 month benefit with abiraterone, enzalutamide, radium-223, and cabazitaxel, you would literally be extending the life of these post-docetaxel patients by perhaps as much as 15 to 16 months. Individually 4 to 5 months, but collectively potentially a year or more. So it's a very exciting time for these patients who previously had no obvious next therapy other than more chemotherapy. I can only say that a patient who has previously had chemotherapy for prostate cancer now has far more reasons for hope than there was even 2 years ago.